Okay, thank you, Mr. Chairman. Thank you, everybody here and abroad then. And so the second topic is on treatment of VTE during pregnancy. So I hope I will have less rumor or less murmurs and a phlegm. That's good. And the question will come later. So these are my disclosure, mainly lectures. So what I want to do with you today is review evidence and guidelines on the management of VTE during pregnancy and discuss the evidence or lack thereof on anticoagulation in this indication. So clinical case again, so prepare your cards. So this time she's 32-year-old. It's her first pregnancy at 27 weeks, and she presents with acute onset of shortness of breath, chest pain, left-sided, pleuritic in nature. On physical exam, not much. Heart and lung auscultations are unremarkable, a bit tachycardic, no symptoms of DVT, no fever, no cough, no hemoptysis, and O2 sat isn't that bad either, but her D-dimer is clearly positive at 750, so she underwent a VQ scan, which is of high probability for PE, confirming the diagnosis here. So first question for you would be, in your institution, or if you see that patient, do you admit her for first days, or do you let her go home? So who admits her? Okay, so it's close to 100%. I didn't see much black here. Okay, I might not, but that's okay. Okay, in terms of treatment options, so again, we'll flip quickly through the 4 options here. So sorry, I will read them first and ask later. So the options are low molecular weight heparin, no transition to warfarin, low molecular weight heparin, transition to warfarin, DOAC at standard dosing, or starting with IV unfractionated heparin for a few days and then 1 or 2. Okay, so who says the first one? Low molecular weight heparin, no transition. A lot of yes. I see a few no. Oh no, change to a yes. Okay, 100% yes. So I guess I don't even have to go, or let's say, okay, option number 2. Okay, only some no. Option number 3. DOACs, I can't see any yes. Okay, and option number 4, some 4. Yeah, okay. But okay, so I think number 1 is a clear winner here. Sounds good. So as you know, and it has been said before, thrombosis complicates 1 to 2 per 1,000 pregnancy and poses multiple challenges, not only prevention, but also diagnosis. And we'll hear some great news tomorrow on that here at the meeting. Treatment, management around the time of delivery, and Dr. Gree will come back to that later. But certainly, despite all our efforts, it remains one of the main causes of maternal mortality in developed countries. So in terms of options for treatment, obviously we used heparins a lot for a very long time, and the beauty of them is that they don't cross the placenta, or even if they do, and they don't cross in the milk either, or even if they were to do that a little bit, then they would not be absorbed orally anyway. Obviously the downside is that it's a parenteral administration, cost is an issue for sure in certain countries. And as you know, for many years already, low molecular weight heparin took over unfractionated heparin for the management of thrombosis, including in pregnant women, and have several theoretical advantages over the unfractionated heparin and practical advantages. So it's a fixed dose, weight-based, no need for daily monitoring in general, and obviously it's a sub-Q administration, not IV. And in non-pregnant women, at least, we have evidence that they are actually doing better than the unfractionated heparin. At the same time, they are more efficient, but they are also safer with less risk of bleeding, less risk of HIT, osteoporosis, and so on and so on. So data is much more limited in pregnant women, but given the above, it became clearly the first option of choice. So vitamin K antagonists do cross the placenta, expose to a risk of embryopathy if they are used between 6 and 12 weeks of gestation, not before, because there is no placental vascularization yet. There is also a risk of central nervous system abnormalities and a risk of bleeding to the baby, because they do cross the placenta, and so the baby is actually anticoagulated as well. And so particularly during the 3rd trimester, there is a risk of bleeding, and particularly of intracranial bleeding. They may be used during the 2nd trimester in some specific situations that mostly applies to patients with mechanical valves, but in some situation we might have to use them in patients with thrombosis as well. One advantage, though, is that they're safe to use in breastfeeding women. So after delivery, if women are willing to switch to an oral medication, there is a possibility to do that with vitamin K antagonists. DOACs, very different situations. They are very small molecules. They do cross the placenta. They pass into the breast milk. And animal studies showed also some signal for reproductive toxicity for rivaroxaban, edoxaban, not for apixaban, but obviously these are animal studies only. In humans, we have very limited data on pregnant women. What we have are registries or series of women who were accidentally exposed to DOACs during pregnancy, and that's the most recent summaries that I could find. And altogether, we know about 236 women who were exposed to DOAC during their pregnancy, mostly to rivaroxaban, a bit less to the other one, as you can see. Fortunately, that was discontinued within the first 2 months of pregnancies, above 80% of them, but some women used it for up to 26 weeks during their pregnancy, and for 48 women, they used it for more than 2 months, or 2 months or more during their pregnancy as well. Of these women, 28% had elective termination. It wasn't possible to say how much of that was actually due to the fact that they were on the DOAC. Rate of miscarriage was significant as well, 30%. So the authors say, well, in that population, we could have expected a 20% rate anyway. It's hard to say because we don't know women's age or we don't know their full history. So we don't know if it's clearly an excessive risk or if it's within an acceptable range, so to speak. And they comment on the 4% risk of abnormalities that were possibly related to the use of the DOAC. And there is an ongoing international registry on that. So if you happen to cross women who were exposed to DOAC during the pregnancy, please include them in the registry so that we can get more data about potential risk or about what happened to them. But clearly, so far, until more data becomes available, pregnancy is a formal contraindication to the use of a DOACs, and the International Society of Thrombosis suggests that when women are treated with a DOAC for a DVT or PE and they plan to become pregnant, they should be switched to a vitamin K antagonist and then to longer weight heparin as soon as they become pregnant. Or you could switch them directly to longer weight heparin prior to conceiving, knowing that obviously it's hard to predict how long it would take before they actually become pregnant. Women who unintentionally become pregnant while on the DOAC should immediately be switched to a longer weight heparin, although for now, exposure to a DOAC should not be regarded as a sufficient reason to terminate a pregnancy too early. Breastfeeding women should not be treated with a DOAC. And again, it's very important to report any case that you would be aware of to health authorities and to the registry so that we can gain more knowledge about that. So back to our patient, she started on a sub-Q weight-based dose of longer weight heparin. Do you monitor her anti-10A levels or not? Yes or no? Is that a 50-50, Ben? 50-50? 70 yes?
73.2.
Yes. That's good. He is good. That's why I asked. Okay. So whatever you decided to respond, you're not alone. So because if you look at what the guidelines say, I must say and I just copied for you their exact statement so that you can see how not strong they are about what they say. The strongest is the ASH most recent guideline suggesting against routine monitoring, but as you can read, the other are pretty vague, saying it's difficult to justify, or there is insufficient evidence to recommend, or we do not recommend except in da-da-da. And on the other side, the ESC, for example, would say yes for valves, and it seems as something reasonable to do for patients with VTE as well. All right, I got the rumor as well. I'm screwed now. Okay. So back to our patient. So we see her a week later for follow-up. She's doing better. Chest pain, shortness of breath have improved. No bleeding, no side effects. And she saw her obstetrician. Pregnancy is otherwise uncomplicated. And before she got the PE diagnosis, the plan was just to go for spontaneous labor, vaginal delivery. So now that you know that she has PE, what will you be doing for her delivery? So 3 options, so no change to the plan, schedule C-section or schedule induction of labor. So who would say, we don't change the plan, we let her go and we'll see what happens? Hey, a lot of yes. Okay, who says I will schedule her for a C-section? No, that's clearly a no. And who says I will schedule her for induction of labor? Okay, some yes as well, but I think I think 50-50 again between option number 1 and option number 3, right? Yeah. Okay. So actually, most of the guidelines say that we should plan these deliveries for women who are on a treatment dose of anticoagulants. And we have a recent paper in the New England Journal showing that induction of labor is not associated with a higher risk of adverse outcomes or a higher risk of cesarean section in pregnant women. Well, obviously not in pregnant women with thrombosis. It was in pregnant women in general. And certainly what we usually typically do is that we distinguish 2 kinds of situations, right? One of which would be a standard risk and a situation in which we feel that the risk is a bit higher based on, how recent the event was, whether it was a recurrent event or not, whether we have underlying strong risk factors and so on. So if it's a standard risk, so for example, in her case, she was diagnosed at 27 weeks. So when 38 weeks come, she's already 11 weeks in treatment. It was her first PE. It wasn't a major clot burden. So usually what's recommended is to do the last dose of the therapeutic low molecular weight heparin on the day prior to induction. No injection on the morning of the induction so that she can get her epidural anesthesia. And then you would resume 12 hours, 24 hours after delivery if there is no abnormal bleeding postpartum. In high-risk patients, so obviously if it's a very recent event, consideration should be given to the placement of an IVC filter, and Professor Gree will discuss that just after. But certainly when you have someone who, say, has been a month on treatment, bad PE or recurrent PE, this type of patient are usually admitted, and then you switch them from the subcutaneous heparin to IV heparin, say starting 12 hours after the last sub-Q injection, no bolus because you got the sub-Q injection before. And it's typical to say stop IV heparin 4 hours prior to anticipated delivery. And I know how impossible that is. So some people say use cervical dilation, some people use just stop when they start the induction and think that's fine as well. And then you resume 6 to 8 hours if it was a normal delivery, 12 hours if it ended being a C-section. All right. So she's doing fine. She delivers. You resume the low molecular weight heparin on postpartum day 1, but at that point she already did 11 weeks of treatment. So for how long should she stay on treatment? Would you say 1 more week so that she has completed 3 months, or would you say 6 more weeks, or would you say 3 more months? So who goes for just 1 more week and then she's good? No. Everybody says no, or almost everybody says no. Okay. Who says she needs 6 more weeks postpartum? That one is good. Get more success on that one. And who says 3 more months to complete 6? And some yes there as well, for sure. Okay, yeah, that's reasonable as well. So certainly minimum duration of treatment should be 3 months, but as you've seen in Anne Flem presentation, the risk is really, really high after delivery. So certainly if you were to stop early during postpartum, the risk would be that she would get a recurrent PE. So we always treat for at least 6 weeks during the postpartum period as well. And then for further management, I usually consider these as being weekly provoked events. As you know, the pregnancies itself is not such a high risk factor in terms of odds ratio for VTE. Postpartum clearly is, but the pregnancy in itself is not that much. So certainly I would consider these in terms of what's her risk of having a new venous thromboembolic event and do some risk stratifications there as well. Some consequences for further management, and as you know, she has a contraindication to the use of the estrogen-containing birth control pill after that, and any future subsequent pregnancy, as we just heard, she should be on long-to-wait heparin for VTE prevention as well. So in summary, management of VTE during pregnancy remains a clinical challenge. Long-to-wait heparin remains a cornerstone of VTE prevention and treatment in pregnant women. And clearly we need more study. And I'm just advertising for the INVENT network, which is a network of the National Clinical Research Network on VTE. And we are trying to promote the internationalization of these kind of studies. And for example, the high-low studies that Anne Flem was mentioning before has been including WHITH being a pregnancy study because the INVENT network endorsed it, and this allowed us to have much more countries participating in the study and helping with recruitment. And with that, I thank you for your attention.